Go for it. Good morning, everybody. My name is Hunter, and today I'll be doing my proposal presentation on optimizing adaptive radiotherapy through automated replanning assessment. My principal supervisor is Senior Simon Goodall across at Genesis Care, as well as co-supervising is Dr. Pedro Roshan Faza and Dr. Jake Kendrick, who I'm all forever grateful to for supporting me in this endeavour. So I'll just give you a bit of a background. So this study will be focusing on head and neck cancer. Head and neck cancer is a broad term which encompasses many malignancies of the upper respiratory through to the digestive tract, including of the salivary glands. Every year, about 900,000 new cases are diagnosed. 70% of such are able to benefit from some form of radiotherapy. Further through, 50% of those are curative treatments in conjunction with some form of other treatment, usually surgery, and the other 50% are done for palliative care, so easing in pain. As can be seen here, we have the two techniques primarily used for head and neck cancer treatment, that being IMRT and VMAT, primarily VMAT at the newer centres, especially Genesis Care. But 3D CRT, as you can see, has a much larger dose distribution and is not ideal and is virtually completely obsolete. As is the case with all radiotherapy treatments, we have very steep dose gradients, which is of particular relevance for head and neck cancer treatment, given the surrounding organs of risk, especially such as the parotid glands, the spinal cord, and the brainstem. The consequences of this is that we often, if we see any anatomical change during treatment, which we'll get to in a second, PTV can be underdosed and we might receive excess dose to organs of risk. That is of particular relevance for the parotid gland, for example, which in extreme cases can cause xerostomia, which can very much degrade quality of life. However, you might be wondering now, why is head and neck cancer of particular interest in this study? And that is due to the static challenges usually associated with the treatment of head and neck cancer through radiotherapy. So when patients are treated, they usually undergo quite extreme anatomical changes. So the primary one being that the PTV shrinks up a lot. The initial volume is quite high, and after only a few fractions, we see dramatic changes in patient anatomy. In conjunction with that, we also have surrounding tissue shrinking, such as the parotid gland. That does depend on where the lesion is itself within the head and neck region. However, that is still relevant. And in general, weight loss is also quite commonly seen across all radiotherapy treatments. But for head and neck cancer specifically, we often see a decrease in neck diameter. And that can obviously shift your contours around from what was originally planned to. So this kind of produces this dynamic set of anatomy. And I've got a little sort of set going on here. So we have external contours changing due to the effects of radiotherapy, like I just discussed. This distorts the dose distribution onto the co-beam CT, which we'll get to in a second. And therefore, we have lower PTV coverage and higher organs of risk dose. So the question must be begged, why is it we are using a static radiotherapy plan when the anatomy is quite clearly dynamic? And that is where, sorry, not yet, we'll get to the current workflow. So most of you will probably be quite familiar with the current workflow that is generally all radiotherapy, except for Genesis Care, we we have a little bit of a second step, which we're hoping to implement during this study. So I'll go over it quite briefly. We have the initial planning CT is taken where the patient is first brought in, and then the oncologist draws all the contours and does dose descriptions and the like. And moving on from that, we have our treatment planning. So that is where the treatment planners work and decide whether or not IMRT is necessary or VMAT, and how much dose we can be giving to surrounding organs. This is obviously very patient specific. And this is the part where the physicist comes in. So dose approval and calculation must be done. And things such as QA must be performed as well on all of the treatment plan that is about to be ready to go for the patient. So then the patient comes in for their first set of daily imaging. Now, this is either in the form of MVCT or megavoltage CT or CBCT, cone beam CT. Cone beam CT is definitely the method of choice, and I believe it's the only system used within Australia for daily image guidance. That's because MVCT has both worse contrast and higher dosage for the patient. And so, yeah, Genesis Care, we explicitly only employ a CBCT. However, a lot of the studies we investigate does still use MVCT, given they are either at or older studies or in different nations where the standards aren't necessarily as high or the technology isn't as rapidly advancing as it is in Australia. So usually the patient would then be guided, given the CBCT, and then they would be treated. At Genesis Care, we have a slightly different sort of methodology. So we can go through the MinMaestro Monaco planning system, and this allows for dose recalculation. So this is pivotal to ART, which we'll be discussing in just a second. And so essentially what has happened, the patient is brought in for their cone beam CT, perhaps the 5th or 10th fraction or 15, kind of arbitrary. And then we project the planning CT onto the cone beam CT through formal image registration. This produces a vector field which maps both the contours and the voxels. Now, this is very important because the voxels themselves on the planning CT, or sorry, that's the Hounsfield units. The Hounsfield units are a lot more accurate on the planning CT than the cone beam CT. And if we were to use the Hounsfield units from the cone beam CT, we would get massively inaccurate dose recalculation. So therefore, we must be going through this process to deform the planning CT on the cone beam CT, and this produces a so-called synthetic cone beam CT, which is what's used for dose recalculation and all of the like. So now we'll get into what actually is adaptive radiotherapy. So the process is quite simple. We are updating the radiotherapy plan in accordance with the physiological or anatomical changes seen during treatment. With the goal is also very simple. We are trying to reduce dose to surrounding organs and increase or better the PTV coverage throughout the course of treatment. So that involves daily imaging, assessment of the geometry of the anatomy once that imaging has taken place, and therefore replanning when some sort of deviations is exceeded. So that's essentially what this study is about. We're trying to figure out what deviations and what tolerances are ideal and when should a patient be replanned. So there's a little bit of a flow diagram here. It's quite apparent. It's plan, treat, evaluate, adapt. So here are some clinical techniques we came across when we were doing the literature review. The techniques are anatomy-based, dose-based, and knowledge-based, kind of going down from advancement, if you like. And then, of course, we have the description of the paper. So the first one being Duma et al., which was one of the almost first adaptive radiotherapy studies, which used a relatively small cohort size in a prospective method. They determined that the replanning trigger should be determined by 5mm soft tissue changes. That was associated when the MVCT, it's a $5 study, so they still use megavoltage, formally image registration through the PCT. They found that with ART, we had a reduction in spinal cord max dose. However, there was no improvement to the parotid gland dose. With Back et al., that was a retrospective study involving a much larger cohort, and they came up with a so-called BART protocol, which was larger than 3mm anatomical changes for major volumes, and that to be on at least 3 out of 4 consecutive scans. They found that the ART was strongly associated with weight loss. However, they didn't actually come up with any exact measures that we can do to determine whether or not ART is necessary. So moving on to dose-based, we have Pitala et al., which was a prospective study, which found that the maximum reduction in dose of the parotid glands, was triggered by the dose exceeding what is clinically acceptable for the carotids, was 3.3 Gray with a mean of 1.5 Gray. So that is significant. Whether or not it actually determines the output of the salivary glands is to be seen. We'll discuss that in the next slide. Interestingly, the next study, Barragan et al., uses dose-based and knowledge-based systems. So this is a very interesting study. This is what ours is actually, in a way, based on. We'll discuss it more later. So essentially, they use iterative protocols to update their initial clinical thresholds that are determined by both dose and anatomy-based systems. They found that they updated these protocols given what an oncologist had decided. So essentially, the oncologist went through and decided what patients should or shouldn't need a replan, and they updated their protocols in accordance with that information. And we can see that the red flags, which are the urgent replans, the sensitivity went up, and especially for orange plan, it went up quite a lot, which is significant and ensures we aren't going to miss any patients. Lastly, we have Kagri et al., which I don't think it would be a medical physics study if it wasn't for some form of AR in there. So we have, there was 100 cohort size, we used 80 training sets and 20 patients that were actually retrospectively treated with this information, and it found that 48% of cases AI correctly indicated that there would have to be positive outcomes for replanning, and 47% of those cases actually had a reduction in dose of risk. So just some current limitations. Firstly, we'll talk about the patient limitations. So a study by Hunter et al. Found that the parotid function isn't actually associated with the need to replan. So the patients that underwent a replan had a reduction in dose of the parotid glands. However, it was not underneath the threshold of which we had a reduction in xerostomia, which is interesting. However, any reduction in dose of the parotid glands is vital and difficult, as the threshold does vary between patients. And of course, we have a lack of standardized replanning, so that does become a problem between clinics. And moving on to workflow evaluations, it does require quite a multidisciplinary team to decide whether or not replanning is necessary and will benefit the patient. So it begs the question, how can we increase patient outcomes whilst also having minimal impact on the workflow that's currently implemented systems? clinic, sorry. And that's where the first aim comes in, which is the decision support tables. So we must quantify fraction by fraction changes for the PTV and organs of risk. You'll see in a second I've got a slide demonstrating this. And this provides some sort of evidence-based framework to decide whether or not replanning is redone. We can decide on clinical-based triggers given the proportion of patients that require a replan. So the methodology is relatively straightforward. We must be executing the formal image registration for the planning between the planning CT and the home beam CT. Therefore, we can extract the dose information through the system we established earlier at Genesis Care. We stratify this into bins and therefore present decision support tables as is shown here. So this is the first aim. So obviously the clinical thresholds will be different at each fraction. So for example, on the fifth fraction, we may be saying the patient's under 97.5% PTV coverage would need a replan or flagged for a replan. But the 15th fraction, that would be vastly different because we would expect more patients to have lost PTV coverage by then. So just briefly discussing the second aim, we have automated workflow. So essentially we would be getting these patients to require a replan and therefore adapting these clinical triggers that we have set in place to the decision from the radiation oncologist. So yeah, that's the sort of methodology we're working through there. We would be adapting and deriving the rules accordingly, hoping to increase the sensitivity and the specificity of the results. So just some brief project benefits. So obviously patient level benefits is quite apparent. Any reduction in PTV coverage and higher dose to organs of risk is not ideal. So if we can be reducing that by any means necessary, that will of course benefit patient outcome, especially when it comes to things like xerostomia and quality of life. This might be particularly relevant to patients undergoing palliative treatment, as they might be obviously don't want to experience massive degradation in quality of life, as the whole point of the treatment is to improve their quality of life in the final years. And yeah, ultimately, we also don't want to be missing out on any patients. So just some workflow benefits. We want to be better improving the distribution of clinical resources. So currently, it takes a long time to reassess patients and whether or not they require a replan. If we have some sort of automated triggers in place, it will completely annihilate that issue essentially, as long as it is in line with what all the oncologists within a clinic have to say about it, because we often see quite a bit of intervariability between clinics as to what clinicians believe is a viable trigger to replan. So if we have something like this system in place, we have a universal agreement between all clinicians within at least a specific clinic. So just some practical challenges of ART. First of all, the accuracy of formal image registration. That is often, that has been debated over the last 10 or 15 years or so. However, there was a study by Watara et al. That found that the formal image registration had much higher accuracy, with certain algorithms showing accuracy beyond 99% for dose recalculation. And there we also have research challenges. So as I mentioned earlier, we don't want to be spending too much time on deciding whether or not a patient requires a replan. And finally, we have workflow challenges. So difference in workflows does make some systems difficult to adapt. If you have not only the difference between clinicians deciding whether or not a replan is necessary, but also differences between clinics in terms of the technology implemented and the system they've got in place, it can often make it quite difficult to implement a universal strategy that works on both what they believe, the clinicians believe, and their technology allows for. And that's it. So thank you.
Thanks, Hunter. Questions?
Yeah. My apologies. The one I sent across is actually the wrong PowerPoint and wasn't updated, so I'm very, very sorry. It's missing the QA bit again, but sorry. Please go ahead. I'm very sorry. There was parts of it that were still wrong, so I'm very sorry.
Sure.
Yeah, thanks a lot. Yeah, I guess I was just keen to understand a bit more sort of like what the patient cohort is and how you're going to like, so you're like retrospectively analysing patients. This has been recently implemented by Genesis.
Correct, yeah.
And you're sort of like, and as like you're saying, so the anything with like the QA, sort of seeing, if you could sort of maybe elaborate a bit more on the.
Yeah, so we plan on having a cohort size of approximately 100. We have to decide how many patients. It depends on how much time it takes to actually extract the information, because that is quite a lengthy process if we're deciding on a relatively large cohort size. And we do want to get to the second aim of deciding clinical triggers. So we're looking at about a cohort of 100, we're hoping so. And yeah, it is all retrospective ART, yes.
And so for each given patient case, So you'll be doing the DIR itself and then sort of compare.
Yeah, so the workflow does that for us at the moment, but it doesn't actually, it extracts the information, but we have to go through and manually do it ourselves, if that makes sense, work through the workflow, because it does perform it, or it doesn't necessarily automatically perform, we have to perform it, so that's probably more answering your question, and that's where the first aim of the project comes from, yeah, extracting that information. Thank you.
And ask as well, so then are you looking at what's triggering the replan, whether it's the dose changes or the actual
Yeah, so that's,
physical measurement of the weight loss?
it's probably dosimetric at the moment, we aren't 100% sure of it,
Yes.
but we will be doing it for both the PTV coverage, which would be more anatomical,
Yeah.
and then dose to surrounding organs of risk will be dosimetric, of course.
Yeah.
And then therefore we'd be updating with what a oncologist believes would be a like ad hoc judgment based on whether or not they think a replanning is necessary.
And you're putting patients through just generic head and neck, no matter whether they've been triggered for weight loss in workflow
Correct.
for the setup, just
Yeah.
Thank you.
Good question.
We should have someone online. I don't know, Martin's online, so either of you can go. Martin, jump in.
Yeah, thanks, Hunter. You said you're comparing against clinician decision to replan. So do you know what basis they're making that decision? I guess this is similar to the previous question. Are they using any dosimetry criteria, or is there and are you looking to replicate their decision or just use dose-based criteria?
Yeah, so thank you for the question. Like I said, there is a study currently that uses dose-based triggers. That is what we are heading towards, yes. So like I said, there might be anatomical changes that we can, if they're quite noticeable, we will be doing that and that'll be a flag. However, it is more going towards dosimetric triggers, correct, yes.
So do you know what the clinicians currently are using to make that decision?
Well, currently, for example, the product glands, we wouldn't want any more than 20 gray being received by a single product gland or 25 by both. So that is one clinical threshold that we could be discussing. There is a number more for such as spinal cord dose and the likes.
I guess in the cohort that you're looking at, where there has been a decision to replan, do you know what that decision was based on?
Currently, we aren't aware. They were done by ad hoc judgment for the relevant radiation oncologists. So we haven't looked into that information yet, but naturally we will be extracting that when we get to the stage of discussing with them the retrospective ART.
Sure, thanks.
Thank you.
All right. Thanks, Hunter. Well done.